state, Your Honor.
Very good. Let's have the jury in. Thank you. Good morning. We'll go on the record in the matter of State of Utah versus Martin MacNeill. He is present with his counsel. The state's attorneys are present, and we are back in the presence of the jury. Ladies and gentlemen, the name of a potential witness was inadvertently left off the witness list that was in your jury questionnaire. You probably remember that lengthy list of witnesses. Do any of you know a woman named Roma Henry? She lived in American Fork in 2007 and worked at the Utah State Developmental Center. She's now retired and lives in Antimony, Utah. Do any of you know that individual, if you'll raise your hand? Okay, the record should reflect no jurors know that individual. You may call your first witness.
Your Honor, the state calls Dr. Scott Van Wagener.
Mr. Van Wagener, would you come forward here to the clerk's desk? Please raise your right hand and take an oath.
You do solemnly swear that the testimony you shall give in the case now pending before the court will be the truth, the whole truth, and nothing but the truth, so help you God.
Yes.
Thank you. Would you be seated right here and respond to counsel's questions?
Good morning, sir.
Good morning.
Would you please state your name for the record and spell your last name?
Sure. Leo Scott Van Wagener. Last name spelled capital V as in Victor A-N, capital W-A-G-O-N-E-R.
And what city do you reside in?
Alpine, Utah.
Okay. And what is your profession?
I'm an emergency medicine physician.
So you are a doctor?
I am.
Okay. And how long have you been a physician?
I've practiced emergency medicine for 15 years.
Okay. I'm just going to ask you a few questions about your background. Can you describe to the jury just briefly your schooling?
Certainly. I attended Kirksville College of Osteopathic Medicine in Missouri. followed by an emergency medicine residency in Columbus, Ohio, at Doctors Hospital for 4 years. And then I did a sports medicine fellowship in San Jose, California.
You mentioned osteopathic medicine. What is osteopathic medicine?
There are two paths to practice medicine in the United States. One is a medical degree in MD, or the other opportunity is what's called a DO, or Doctor of Osteopathic Medicine. Training as a DO is very similar to a medical degree, but in addition we get training in manipulation, manual medicine, wellness, and the thought that the body has the ability to heal itself.
Where is your current employment?
American Fork Hospital.
And you've been with American Fork for how long again?
8 years.
8 years. And what's your position? What's your title there at the hospital?
I'm an attending physician in the emergency department.
Okay. With respect to, do you have any obligations in your profession in regards to continuing education?
Yes, we have a requirement, a 3-year cycle, to do 120 hours of continuing education. That has to be submitted to the national board, has to be relevant to my specialty.
Okay. Are you current on that education?
I am, yes.
Okay. What certifications or licenses do you hold?
I hold a license to practice medicine here in the state of Utah. I'm also board certified in emergency medicine through the American Osteopathic Board of Emergency Medicine. Was board certified in '99 and recertified in 2009.
Okay. Are you a member of any professional memberships?
Yes, I'm a member of ACEP, American College of Emergency Physicians, the American College of Osteopathic Emergency Physicians, and a member of the State Medical Association.
Okay. Prior to your experience at the American Fork Hospital where you currently work, did you have previous experiences in an ER setting, emergency room setting?
Yes, I did.
And what were those?
During my fellowship, I worked at Santa Clara Valley Hospital, which is a level 1 trauma center in San Jose, California. I worked 6 years at the University of Utah Medical Center, and then 9 months at Utah Valley Regional Medical Center here in Provo before working full-time at American Fork.
Okay. Thank you. Would you just briefly describe for the jury what your duties are at the hospital in the ER?
My duties are to assess and evaluate anybody that presents to the emergency department for care. Through interview and evaluation, physical examination, make a determination whether or not they have an emergent condition, stabilize them, and make a decision as to whether or not that patient can be discharged to home. Do I need to get a specialist involved? Does that patient need to be admitted to the hospital?
What kind of ailments or injuries are you dealing with on a daily basis?
You know, we see the breadth of illness and medical problems. Fractures, strokes, heart attacks, abdominal complaints, pneumonia. We see everything.
Okay. Taking you to this case, Dr. Van Wagener, are you familiar with Martin MacNeill?
I am.
Do you see Mr. MacNeill in the court today?
Yes.
And where is he seated?
Seated to my left here at the table.
Can you describe what he's wearing?
Blue suit with the blue tie, white shirt.
Thank you. If the record would reflect, the witness has identified the defendant, Your Honor.
Please stipulate, Your Honor.
Thank you. The record will so reflect.
Did you know Dr. Martin MacNeill? Do you know what Mr. MacNeill did for a profession?
Yes.
And what was that?
He was the director at the Utah State Developmental Center.
Did you have occasion to interact with him?
Yes, I did.
And what was the nature of that interaction?
Typically, that interaction was by phone, where a patient or a resident at the developmental center had come to the emergency department to be evaluated. I would then call and communicate with him my findings and decision as to whether or not the patient needed to be admitted to the hospital, could return to the developmental center, and communicate, you know, kind of what was our next step as far as care.
Do you recall what kind of issues you were dealing with as far as ailments or injuries?
With those residents, a lot of the time it's more of a medical problem, abdominal complaints, frequent episodes of pneumonia. Those are probably the biggest issues that we see coming from the developmental center.
Okay. And how often did you deal with Mr. MacNeill?
Not infrequently, but not on a regular basis, maybe once or twice a month at most.
And you said that was mostly over the phone?
Yes.
Okay. I'm going to take you back to April 11th, 2007.
Okay.
Do you recall that date generally?
Yes, I do.
Do you recall having occasion to work on a patient by the name of Michele MacNeill?
Yes, I do.
Okay. Where was that?
That was in the emergency department at American Fork Hospital.
Okay. What were the circumstances? How did you come to work on Ms. MacNeill, Mrs. MacNeill?
The circumstance was we received a phone call from EMS personnel that they were bringing in a woman who was at that point in cardiac arrest.
Okay. And what happened?
The patient arrived having had pre-hospital care given, including intubation, where she'd have a breathing tube placed in her trachea to breathe for her. She was having chest compressions done and had received medication per ACLS protocol to try to revive her and get her heart to start again.
And that protocol, what does that amount to? What is that protocol?
The American Heart Association has established treatment for these kind of cases, including uses of medications that are found to be life-saving, epinephrine, atropine, taking care of airway control to breathe and ventilate for the patient if they can't do that on their own.
Okay. You mentioned she was intubated.
Yes.
Can you describe, where was she intubated? Was that prior to arrival?
She was intubated in the field prior to arrival, prior to me seeing her in the ER, correct.
Okay. Can you explain, was she ever suctioned? Was her airway ever suctioned?
We suctioned her in the emergency department. I don't believe she was suctioned in the field. We did so in the ER.
And how did that happen? Can you describe that?
When a patient presents to the emergency department in this kind of condition, we have a team that's assembled, including respiratory therapy, and the respiratory therapist will often suction their airway through the endotracheal tube if they feel like we're having problems trying to ventilate the patient because of maybe fluid or blood or something in their airway.
Okay. Are you familiar with the term code?
I am.
When someone is coding?
Yes.
What does that mean?
A code is when somebody, it can happen for several reasons. If you hear a code in the hospital, it could be because somebody's had a heart event, and they've had an unusual heart rhythm, maybe they've had a respiratory event, okay? For some reason, they are not doing well, and most likely it's a breathing or a heart issue.
Okay. When Michele MacNeill presented at the ER, what were her symptoms? What did you observe on her with respect to breathing, a pulse, skin color, temperature, things like that?
At the time she arrived, and looking at my notes and reviewing for my testimony, she didn't have a pulse, she didn't have a blood pressure. She was being bagged, which means that we were using an artificial device to push oxygen into her lungs and ventilate her, and she's having chest compressions done.
Okay. Did you observe her skin color, how she presented?
Yes.
How did she look?
Discolored, particularly from the breasts up, kind of bruised, almost discolored that way, bluish tone.
Okay.
There were signs of her recent plastic surgery that she had done with her face and bruising that I think was appropriate for the surgical procedure. She also is noted to have what's called lividity, where she had pooling of blood in her buttock and back.
Let's talk a little bit about that. So lividity, you said it's the pooling of blood. Can you describe again what lividity is and how it occurs in the body?
Lividity occurs over time in a deceased patient. It can occur as early as about 30 minutes after the heart has stopped, and occurs when blood moves in relation to or as a result of gravitation to a dependent portion. So if someone is lying on their back, lividity will form on the buttocks or back or maybe on the backs of the legs. It looks like bruising, bluish tone.
And that can form as early as 30 minutes
Can
following death?
start about 30 minutes after the heart has stopped.
Do you have any experience with respect to the timing of that in your profession? Is 30 minutes routine, or is it?
I can't answer that for sure, but I do know it can start about 30 minutes. I don't see that often
Okay,
in patients that come in that condition.
okay. And you observed some lividity on Michele.
Yes, I did.
And where again was that?
That was on her back and buttocks.
And what does that indicate to you with respect to body position?
With respect to body position, she would have to be face up, because the way lividity develops, because it's in a dependent position, she would have had to be face up for the lividity to be on her back and buttock.
Okay. Did you have occasion to come into contact with her skin? And if so, did you notice what the temperature was or how it felt?
I don't recall if I checked her temperature by touch. No, I don't.
Okay. When she presented, was she alive?
I think she was dead at the time she arrived at our door.
And what tells you that?
Several things. The length of time that we've tried to do a resuscitation, I don't know exact timing as to how long she was being treated by EMS, but a relatively young woman, age of 50, you would think we'd be able to get some kind of cardiac activity back based upon the efforts given. Between drugs, chest compressions, ventilation, you would think that we would have some kind of cardiac activity when she arrived at the ER.
Therefore, you did not see any cardiac activity?
None.
Okay. Do you recall at what time she arrived at the ER? Do you have that in your notes?
12:25
12:25
p.m.
p.m., so just after the noon hour?
Yes.
Okay. When you were working on her, can you describe what the staff is doing and what you're doing?
So again, our response as a team, okay, which includes nursing staff, tech staff, myself, respiratory therapy, all working to try to revive and resuscitate this patient. Everything else in the ER now is secondary because all of our attention is to this patient, okay? Everybody has essentially assignments. Typically, the ER techs will be doing chest compressions. I'm involved with ordering medications and drugs. Pharmacists will often be there helping us administer those medications and monitoring what's going on with the patient.
Okay. With respect to medications, are you aware of what medications were administered to Michele by you or your staff?
Yes.
And what were those?
Epinephrine, bicarbonate, sodium bicarbonate, and calcium.
Calcium. And what's the purpose of calcium?
Calcium can be used in these situations for several reasons. One, it can be used in a setting of hyperkalemia or elevated potassium. Sometimes I will, kind of as a last-ditch effort, give calcium to help with contractility, allowing or helping, hopefully, the heart to beat and beat more effectively.
Did that have any effect?
No.
What about the sodium? I believe you said sodium bicarbonate?
Sodium bicarbonate, yes.
Bicarbonate.
That is given to help restore the what's called acid-base balance. In somebody who is in cardiac arrest, you develop what's called an acidosis because the heart's not pumping, blood's not being distributed to the body, and the normal metabolic processes that occur in the body fail. And the more acidotic you are, the less likely that you're going to be able to survive and less likely that you can revive a patient. Sodium bicarbonate was given in the field. I gave it in the ER to try to get that acid base back to a balance point.
What effect, if anything, did that have on Michele with respect to life-saving efforts?
That had no effect.
No effect. And then finally, the epinephrine. What's that given for?
Epinephrine is adrenaline, right? And we use that to, one, try to help increase heart rate, but also increase the ability of the heart to pump, okay, strength to contraction. It's the same process in your body when you're scared. It's the fight or flight drug. So you think about being scared and running away, it's going to increase your heart rate, increase your ability to pump more effectively. The other thing that epinephrine does is that it dilates or opens up coronary vessels, the blood vessels that take blood to the heart itself.
Okay. And the effect, if any, on Michele that day?
That had no effect.
No effect, okay. May I approach, Your Honor?
You may.
May I have continuing permission to approach?
You may.
Doctor, I'm handing you what's been marked as State's Exhibit number 33. Do you generally recognize what that is?
Yes, this is a toxicology report.
I'm going to direct your attention to the lower portion there. There are several drugs that are listed. Did you, with respect to your work on Michele MacNeill, ever give her any diazepam,
No,
promethazine,
no,
zolpidem,
no,
oxycodone?
no.
Okay. And why wouldn't you have administered those drugs to her? Just briefly.
Those medications aren't indicated, in cardiac arrest, and those medications, particularly the oxycodone and diazepam and zolpidem, are sedatives. They're not indicated in this kind of condition.
There was a paramedic that indicated that these kinds of drugs are contraindicative of what's going on in trying to save a patient. Can you describe what that means?
Contraindicated is just what it sounds like. It means that they're not indicated in particular cases, okay? All these drugs have a purpose, and all drugs that we use have indications. The drugs we used as ACLS protocol, the epinephrine, the sodium bicarbonate, all are in an intent to help resuscitate or revive the patient and get their heart pumping again. These medications listed in the toxicology screen, diazepam is a sedative, also used as a muscle relaxant, oxycodone is a pain medication. Those aren't medications we would use in a code situation.
Okay. Can I have just a moment, Your Honor?
You may.
Your Honor, the state offers State's Exhibit 33.
Any objection?
No, no objection.
33 is received. Thank you.
The term poorly, or the phrase poorly perfused skin, what does that mean, doctor?
Poorly perfused skin, one of the things you can look at as far as perfusion is what's called capillary refill. So if you were to squeeze your fingernail on your index finger, your nail goes white, it blanches, and then it returns back to normal pink color, typically in under 3 seconds. That shows you have good perfusion. If you were to push on somebody's skin or on their fingernail bed and it's longer than 3 seconds, 5 or 6 seconds, that means they have poor perfusion, that there's not adequate blood, or the blood flow to their skin and their nail beds is not very good.
Okay, thank you. Do you have occasion to perform CPR in your employment?
Yes,
How frequent do you do that?
2 or 3 times a month.
Have you been trained extensively in the subject?
Yes.
Can you tell us how to properly perform CPR? How does that happen?
CPR, the way we perform it now, is a little different than 5 or 6 years ago. The acronym ABC used to be used, standing for airway, breathing, and circulation.
Were the ABCs, was that approach the norm in 2007, April of 2007?
Yes.
Okay, so that's since changed?
That's changed to what's now called CAB, C-A-B, standing for circulation, airway, and breathing, with more of an emphasis on chest compressions and helping, blood flow move through the body.
Okay. Will you just describe to the jury how to properly perform CPR?
So based upon the acronym CAB, C stands for circulation and involves chest compressions. And somebody's found unresponsive, you check a pulse. If they don't have a pulse, you start chest compressions and administer 30 compressions. If there's somebody else available, you send that other person for help to try to get professional assistance and make a 911 call and get EMS there.
In performing these chest compressions, can you describe how physically you are to perform those?
The most effective way to perform compressions is with arms locked using your weight, okay, rocking back and forth on a person's chest. In an adult, you probably should compress the chest about 2 to 2.5 inches. It's strenuous. We switch out during a code in the ER probably every couple of minutes because it's hard work.
Okay. What about the body position of the patient being worked on?
We use in the ER some kind of a hard board or a slab underneath the patient on the bed with them face up,
Okay.
supine.
Can you effectively perform CPR on someone on a mattress?
I don't know how effective it would be. I think you could do it, but because you're not doing chest compressions against a solid surface, it's going to be more difficult and less effective.
Okay, thank you. So we've gone through the C. What about the A?
The A stands for airway. So once you've done the C, once you've done 30 compressions, the next thing is to deliver 2 rescue breaths. And in order to do that, you need to open the airway. And there's several ways to open the airway. You can do a chin lift or a head tilt where their head goes back, or you can also do what's called a jaw thrust. And the idea is to line up the oral pharynx or your mouth with the trachea to allow air to move into the lungs.
And can someone's airway be obstructed?
Yes.
And by what, generally speaking?
Often the airway is obstructed by a person's tongue. If someone is unresponsive, their tongue relaxes, falls back in their airway, and obstructs the tongue. By opening the airway with the chin lift or the jaw thrust, you get the tongue out of the way and allows you to give rescue breaths and get air into their lungs. It could be obstructed by vomitus, by a toy in a child, something else in the airway could be obstructing the airway.
What about thick mucus? Could that affect it?
It'd have to be pretty thick, maybe. I mean, more likely we see in patients vomitus and emesis, particles of food that are blocking the airway.
Okay. What about water? Is water an obstruction?
No.
Okay. Now we're to B. What's B?
B stands for breathing, okay? And that's where you administer rescue breaths. Bystander CPR, you're doing mouth to mouth or doing a mouth to some kind of a device, a mask that maybe you have a pocket mask. In the hospital, we use either the patient intubated with the tube in their trachea, or we're using what's called a bag valve mask that has a mask with a cushion over their nose and their mouth to administer breaths.
Is that an ambu bag?
That is an ambu bag,
Okay.
also called a bag valve mask.
If someone were to give breaths not using a bag, but just mouth to mouth, as it's understood, what's the process of properly giving mouth to mouth? What do they physically need to do?
Physically, again, you need to align the airway, so with the chin lift or jaw thrust, and then including the nostrils and opening the mouth and placing your lips and mouth over their mouth to give an adequate breath.
Do you squeeze the nostrils?
Yes.
Okay. Does it create a seal?
Should create a seal. Your lips should create a seal around their mouth and their face to administer that breath.
If it doesn't create a seal, what's going to happen?
If you don't have an adequate seal, that breath will be pretty ineffective. And then the way you can tell whether or not you're administering a proper breath is looking for chest rise.
Okay. If you don't see chest rise, what's next?
You need to reassess the situation. Is it because I've got an obstruction? Is it because I don't have adequate positioning? So reposition my head by head tilt or chin lift or jaw thrust. Or is there some kind of obstruction? Again, is it the tongue, or is there something in the airway, a particle of food or something else that's not allowing that breath to go into their lungs?
Okay. So if someone's giving an adequate breath, you will see the chest rise.
You should, yes.
Okay. Doctor, I'm going to direct your attention to this bathtub. We're using this for demonstrative purposes here. If you were attending to a patient, and the patient was inside of this tub, and for our discussion purposes, we'll place the crown of the patient's head about right here, just a few inches above the top ring of this tub. The patient is looking forward, so he or she's on the back, buttocks area, with the legs down here, sort of curled inside the tub.
Okay?
If I were administering CPR, could I effectively perform chest compressions if I were either on one knee here or hovering over the patient attempting to perform compressions?
I think it would be difficult to get adequate chest compression. Because of the angle of the person, angle of the patient. I think as you pushed, you would push the patient or the victim down into the bathtub further, and not be able to get adequate compression and chest motion.
When you're giving chest compressions, where is the administrator putting his or her hands?
The lower part of the sternum.
Can you point to that on your body?
So the teaching is if you feel your xiphoid process, which is the bottom of your sternum, you come up about 2 finger breaths to the lower part of the sternum, use the heel of your hand on that part of the chest, and typically overlap your other hand to begin chest compressions in that manner.
And when you're giving compressions, are you pushing straight down,
Yes,
2 to 2.5 inches like you described?
correct.
So if I were, again, on one knee or hovering over and trying to do that, how effective, what's your opinion on how effective I could be?
I think it would be pretty ineffective. The angle's wrong. You're not being able to push straight down. If you're trying to push straight down, likelihood your hands would slip, or you're just going to push the person into the bathtub itself.
Okay. If the patient's head was not, say, a few inches above, but more flush with the ring, the top ring of the tub, would it essentially be the same
Yes,
as far as the effectiveness of the chest compression?
I would believe it would be.
With respect to the airway, if the patient was in the position that's been described and the head was tilted down, what effect is that going to have on the airway in giving breaths?
So again, in that position with chin to chest, the airway is going to be most likely occluded. Again, we talked about,
And when you say occluded,
means it's blocked.
okay.
We talked about chin lift, jaw thrust, head tilt. Those kind of things will open the airway, align the airway. Chin to chest occludes or blocks the airway.
Okay. It's in fact the opposite of tilting the head back.
Correct.
That position described.
Correct.
With respect to the breaths, again, if the patient were in the bathtub in that position and I were down, how effective would I be able to perform breaths on an individual in that position?
I think it would depend where they are in the bathtub and the position of their head.
If their head was slightly above the ring or flush with the ring, again, tilted down or maybe even tilted up a little bit.
You may be able to get some breaths, but if their head is down below the ring, again, I think you're going to have a problem because most likely the chin will be towards the chest. And those axes of the airway and the back of the mouth aren't aligned, and you're not going to be able to have the airway open.
Okay. So you've talked about the CAB approach.
Correct.
It used to be an ABC approach. Would you just briefly describe what the ABC approach is and why the change?
So the ABC approach, again, is the same letters, just in different order. A stands for airway, B is breathing, and C is compression. I think because of what we've learned about cardiac arrest, where most of these are because of a dysrhythmia or a heart rhythm problem, that compressions was moved to the forefront. The thought that if we can keep blood moving throughout the body until we get professional help there, or somebody shows up with what's called an AED, an automated external defibrillator, and can deliver an electrical shock, that's probably more important at this point than opening the airway and breathing. That's how it is most of the time.
Okay. Considering this approach to CPR, as it applies to potential drowning victims, how do you treat a drowning victim?
Drowning victims are different in that the reason that their heart has stopped is because of what's called hypoxia. Hypoxia is where you have a low oxygen state in the blood, and because of that, the heart doesn't do well, and eventually will stop. The approach to a drowning victim is different in that the most important thing we can do is try to ventilate them, breathe for them, and get oxygen to them. The thought is, and even recommended by the American Heart Association, is that in a drowning victim, the most important thing to do would be to administer breaths first, 5 breaths initially, before we start doing other things as far as airway, as far as airway and chest compressions. So ventilation is paramount in a drowning victim.
Okay. It's also true that chest compressions will administer oxygen to the body as well, correct? Through the blood?
Yes, and that's the intent, is to keep blood flow moving, to try to keep oxygen going to vital organs.
Okay. Were you trained in CPR in medical school?
Yes.
Are all doctors trained in proper administration of CPR?
I would think they are, correct.
In your experience, how common is it for doctors to know how to properly administer CPR?
I think it's one of the basic tools, the basic expertise that a doctor has, is to be able to administer CPR. And depending on your training, you also have to, every 3 or 4 years, recertify in ACLS to be able to continue that certification process and to be able to work in most of the hospitals.
Okay. Thank you, Doctor. I take you back to this case, April 11th, 2007, in American Fork at the ER. Did you form a working diagnosis with respect to Michele MacNeill, what was happening to her?
Yes.
And what was that?
First on my list as far as working diagnosis is that of what's called a pulmonary embolus.
And what is that?
Pulmonary embolus is where a blood clot has gone to your lungs and causes problems not only with oxygenation, ventilation, but also can cause problems with your heart.
And how does a pulmonary embolus come about?
Pulmonary embolus can occur for several reasons. Typically it comes from somewhere else in your body, like your legs or maybe your pelvis. Typically there are risk factors for forming a clot. Surgery is one, immobilization one, people get them when they travel. Smoking is another.
Okay. And what's a saddle embolus?
A saddle embolus is a large pulmonary embolus that sits atop the outflow tract, like a saddle does on a horse, the outflow tract from the heart to the pulmonary arteries.
Okay. And describe the complications with a saddle embolus.
Most people don't survive a saddle embolus. Most people immediately succumb to a saddle embolus because blood flow has been immediately blocked. And large saddle embolus completely blocks any outflow of blood from the heart to the lungs.
Okay. And so you came up with a working diagnosis, an embolus on the part of
Michele. That, in my mind at that point, that was the most likely, based upon her recent surgery. Most likely she'd been recovering, convalescing at home, probably hadn't been real active. And for her to present as having passed out or having a syncopal episode, my thought was that she probably had
episode, did you say?
a syncopal episode, which means you've passed out.
Okay. Generally speaking, in your community, the medical community, who is the best person situated to determine actual cause of death? And is it different from one case to case?
I think that's case by case.
Okay. Can you describe that?
There are cases where patients come to the hospital, come to the ER, that die where I immediately can recognize or know the cause of their death.
Like what, for example?
Myocardial infarction, a heart attack. Okay, somebody could succumb from that. A gunshot wound where they've bled out.
Okay.
A stroke, okay, where they've had either a clot or bleeding in their brain. That's pretty identifiable because typically we'll have some kind of an image, a scan that shows what's going on.
Okay. With respect to Michele MacNeill, who's the best person to determine cause of death, you or someone else?
In this case, I think probably someone else.
You're familiar with a medical examiner?
I am.
And what is a medical examiner?
Medical examiner is a specialist who will do an autopsy or a postmortem exam to try to determine cause of death.
Okay. And who would be the best person situated, the best person in this case of Michele MacNeill to determine her cause of death?
I think in this case the medical examiner would be, because we didn't have a chance to do any real diagnostic test to try to decide her cause of death.
Did you contact the Utah State Medical Examiner or their office in this matter?
I did.
And do you recall who it was that you contacted?
Sheriff Spencer Cannon.
Do you know what his relationship was to the medical examiner's office?
I don't know. I've contacted him several times. I don't know if he's one of the officers who's on call to help assist with medical examination and transport of patients when that occurs.
Okay. Can you describe why you contacted him in this case?
I felt this case was unusual, and a lot of times we'll contact the medical examiner because of that, where we don't have a certain cause of death, and in an unusual death in someone that we wouldn't expect to die.
Why was this death unusual, in your opinion?
Michele was young, age 50, relatively healthy, presents in cardiac arrest with no known, in my understanding, no known heart history. And for her to die in that way without a certain cause, it becomes a medical examiner's case.
Okay. Going back to the day in question at the ER, did you see the defendant that day?
Yes,
And where did you see the defendant?
in the emergency department.
Do you recall when you first saw him in relationship to first attending to Michele?
He arrived, based upon my notes, which I have with me, he arrived the same time the ambulance did.
And what did you notice? What was he doing, the defendant?
He was in the room with us, which we often do now, allowing family members to be in the room during resuscitation. At times agitated, at times somewhat seeming angry.
Did he ever say anything?
Yes.
What did he say?
He made comments asking or stating kind of why did she have to have the procedure done, talking about the plastic surgery, saying that he was upset that she had had that performed. He made an odd request of me, which I still find to be, in 15 years of practice, completely unusual and really kind of off the wall.
What was that request?
He offered me $10,000 to continue my resuscitation and not quit.
Do you recall when he made that offer in relationship to him being at the ER, his arrival?
It wasn't on arrival. It was sometime in the midst of the resuscitation and doing everything that we were doing.
Why was that odd to you?
I'm not sure how to answer that question. It's just that I'm not sure where that came from or why he would make that offer. I think as a physician, he probably knew that his wife was already dead, knowing that we hadn't had any signs of life, no blood pressure, no pulse, no breathing on her own. I'm not sure why he made that comment, and this struck me as very odd and still remains odd when I think about it.
Okay. Did he ever speak to you or make any statements with respect to what he believed happened to Michele?
My understanding, and again looking at my notes, he thought she had had a syncopal episode, that she had passed out and had fallen into the bathtub.
Did he describe what he did upon finding her?
It says here again, looking at my notes, that he pulled her from the bathtub and started CPR.
Okay. Do you try and collect history from someone who would know about the patient?
Yes.
And what's the purpose of that?
Part of the history is to determine the length of time that maybe somebody's been sick, what symptoms they've had. In the case of maybe somebody who's having pain, where the pain is, what the pain's like. Help me try to, in my mind, as I go from history to physical exam, develop what's called a differential diagnosis, or a list of things that may be causing those symptoms.
Okay. Did you collect any history from the defendant with respect to Michele MacNeill?
Yes.
What was that?
I asked about the recent cosmetic surgery, the plastic surgery she had done, how long he had been away from Michele. I hadn't seen her.
What did he say with respect to that?
It says here 1.5 to 2 hours that he had not seen her.
Okay.
Asked other things about pertinent history, whether how she'd been recovering from the surgical procedure, had she had any chest pain or shortness of breath.
What were his responses to those questions?
None of that. So she seemed to be recovering well from the surgery, hadn't had any shortness of breath, and not had any chest pain.
Your Honor, I'll pass the witness for now.
You may cross-examine.
Good morning.
Good morning.
You've indicated you've referred to your report
Yes, sir.
to refresh your memory,
I have.
and you've had a couple opportunities to talk about the events on April 11th of 2007, correct?
Correct.
And one of those was at a preliminary hearing that we did about a year ago,
Yes.
and then another occasion was on August 3rd of 2009 when you met with investigators Whitney and Robinson.
Correct.
I want to talk to you first about your experience with CPR. You've indicated that it would be very difficult to effectively perform CPR if somebody was in a tub, correct?
Yes.
If you could not effectively perform, if you could not lift somebody out of a tub to perform CPR on a flat surface effectively, would it not be reasonable to do the best you can with the circumstances you have?
I would say it is. Correct.
And you indicated that in a suspected drowning, the most important thing would be ventilations, correct?
Yes.
And if somebody is seated in a tub, fair to say that you could tilt their head and do mouth to mouth and ventilate a person?
You could, if you had depending on their position, you may be able to get their way open.
And when you let go of their head, obviously it would tuck back down if they were not alive, correct?
Correct.
You indicated that all physicians are trained in CPR in medical school and at other times during your practice. Fair statement?
I did.
When did you graduate medical school?
1993.
And since you graduated from medical school, there have been a number of changes in what I believe you described as the ACLS protocol.
Correct.
What does ACLS stand for?
ACLS stands for Advanced Cardiac Life Support.
And back when you were in medical school, one of the elements of medical professionals administering CPR that could be used was called a precordial thump.
Correct.
And a precordial thump would be administered by the bottom of a closed fist with a thump on towards the bottom of the sternum. Is that correct?
Typically, I've administered it, and I would do it over the sternum, central part of the chest.
Central part. Okay.
Yes.
And the purpose of the precordial thump is to try and restart the heart or to stop an arrhythmia or something to that effect. Is that
Yes, that's true.
You indicated that obviously you're familiar with the ambu bag and
I am.
using that. And an ambu bag has the ability to administer a much stronger pressure of air than is ideal in CPR, correct?
It can.
And a person using an ambu bag, if they do it in a way that it has a stronger air pressure, that could result in filling up the stomach even with air, correct?
And that's one of the side effects or risks of using an ambu bag without airway protection like an endotracheal tube.
Right. And so, and as far as an endotracheal tube goes, a police officer wouldn't be qualified to insert an endotracheal tube.
No.
That would have to be done by a trained paramedic.
Correct.
And in this case, I believe you testified that she was intubated with an endotracheal tube before Michele arrived at the hospital.
That is correct.
Okay. But prior to that intubation, her airway would be described as an unprotected airway.
Correct.
And so use of an ambu bag could result in filling up the stomach with air, which then could lead to vomiting.
It can. Yes.
And that could occur irrespective of whether a person drowned or not, correct?
With air in the stomach?
Yes.
Yes, it can.
When we talked at the preliminary hearing, you indicated that you don't have any specific recollection of when you noticed lividity on Michele's body. Is that correct?
I don't recall my testimony.
May I approach, Your Honor?
You may.
So if you turn to page 633.
In which document, sir? In the big one?
In the big one, yes. Thank you. Prelim.
633.
Yes.
Okay, I'm there.
Okay, and if you look at lines 11 and 12, actually, I guess 12 and 13, I asked you, and you don't have any recollection of when you noticed lividity, do you? And what was your answer?
I said I would say that's true.
And fair to say that your memory isn't better today than it was a year ago?
No.
It's not fair to say that?
It's fair to say that it's not better.
So that was a bad question, wasn't it? I'm sorry.
You keep giving me those, Mr. Spencer.
I do, and I take full responsibility for it, and so I will try and do better. As you sit here today, you don't recall when you noticed the lividity?
No, I don't. Looking at my notes, though I do comment under extremity exam that there was evidence of lividity, but again, I'm not exactly sure as to timing.
Right. You don't know whether that was when she initially arrived or during the process or towards the end?
That's true. That's fair to say.
Thank you. Soon after Michele arrived, you noticed what you termed in your report as cyanosis, correct?
Correct.
And that's a bluish discoloration from the breast up?
That is correct.
And that is oftentimes a symptom of a saddle embolus, which was your working diagnosis.
It can be an indication not only saddle embolus, but also a large pulmonary embolus or some other kind of obstruction that's not allowing ventilation and oxygenation, particularly to vital organs, the lungs, and the heart. And I've not seen that. I've seen that before, not in this case by itself.
Okay. And because of your working diagnosis of an embolus of some sort, you administered a medication called TPA.
Yes.
And that is a clot buster type medication.
It is, yes.
And you administered initially a bolus of TPA
Correct?
and then started a drip in the IV.
Yes.
And the purpose of that would be to break up any clot that may have been obstructing.
Again, based upon my working diagnosis, kind of as a last-ditch effort, giving her any chance of survival, I chose to administer TPA.
And so you indicated in your testimony with Mr. Grunander that you believe that Michele was dead when she arrived at the hospital,
Yes, I did.
meaning that her heart had stopped and she wasn't breathing on her own either, correct?
That's correct.
But you didn't consider her in a state that there was absolutely no hope of reviving her, correct?
That's correct. You know, sometimes patients, particularly like this, that present, again, fairly young, without apparent cause for their condition, without real history of significant medical problems, I felt it was appropriate to continue our efforts and give her every opportunity, or give ourselves as well every ability to maybe revive and resuscitate her.
And you continued to endeavor to do that for about 38 minutes.
Correct.
And in addition to administering the the TPA, you also attempted to start a central line. Is that correct?
Part of the challenge we had was IV access, and so I attempted to do a central line in her femoral vein, and unfortunately we were unsuccessful.
She did have an IV when she arrived at the emergency room, correct?
I don't know if she had an IV. I know she had an IO, an intraosseous line that we administer medication through.
Yes, and you administered that towards the end of your resuscitation efforts, correct?
I don't recall when that was put in.
The intraosseous line you're referring to is the one that was down below the...
It was in her tibia, yes.
And it's common for paramedics to begin an IV in resuscitation efforts before somebody arrives at the emergency room, is it not?
Absolutely.
And do you not recall her having an IV when she arrived?
I don't remember. I imagine she probably did because they administered drugs. I mean, there are several options, excuse me, several ways to administer medication, either through an IV or through the IO. Based upon what they'd done, knowing that they had given drugs, including the epinephrine, atropine, most likely she had an IV. I'd have to look at the notes on the run sheet from the paramedics to make sure.
And also regarding the paramedics, you had some communication with them by telephone?
Correct.
And it was your understanding that they had administered glucose as well in the field?
Yes.
And when Michele arrived, you checked her glucose level, correct?
I did, yes.
And that level was 677?
Correct.
And normal is 80 to
110.
110? And so you weren't surprised with a glucose level that high because you believe that the paramedics had administered it, correct?
Yes, she had received some dextrose en route, some sugar en route. It's high.
In your testimony today, you indicated that when you looked at Michele's body, you observed the cyanosis and you described it kind of as bruising. But you didn't actually see any bruising as if it were from trauma.
No, I use the word bruising because of the color. Cyanosis is similar in that it looks like bruising because of the bluish discoloration. It was not bruising. It was cyanosis.
And the only signs of trauma that you noticed on Michele's body were the incisions from the recent plastic surgery, correct?
That's correct.
And you described those incisions as gaping open, correct?
I don't know if I used the word gaping. My notes here say that they were broken open and split open. I did not use the word gaping.
And you've indicated in the past that they were that you were surprised that 8 days post-surgery that there wouldn't be more evidence of healing.
I did.
In addition to administering TPA in relation to your concern of a saddle embolus, you also had a check for a blood test called D-dimer, correct?
Yes.
And that is another potential indicator of a pulmonary embolus?
It can be. D-dimer is a test that we'll often use because it has what's called a high negative predictive value. If you do what's called a pre-test and determine pre-test probability of a patient having a clot, the D-dimer can be helpful in deciding whether or not you need to go on and do further tests. D-dimer, however, can be what we call false positive. Having surgery can make the D-dimer falsely elevated. Being in the hospital and immobilized can make the D-dimer falsely elevated.
In cases like that, the D-dimer may be falsely elevated to maybe 2,000, 3,000, correct?
I think it's hard to say how high. You know, who knows? Looking at my notes, I indicated that we were going to draw blood so the medical examiner would have access to it, and that included a D-dimer.
Michele's D-dimer was actually greater than 20,000, correct?
I never saw the results.
In addition to drawing a test for D-dimer, you also had a metabolic panel drawn,
I did?
correct? And
Yes.
a CBC
Yes.
test drawn?
Mm-hmm.
And those reports would have been submitted to the medical examiner?
I believe they were.
During the course of the resuscitation efforts, you also had blood gases drawn,
Yes.
and those would have involved essentially inserting a needle in the wrists of Michele?
That's a common place to get it. You can get it from other places, but I think in this case we did get that from her wrist.
And you had 2 blood gases, and so likely one would have been one wrist, and then the second would have been the other wrist?
Hard to know. Depends on where we were able to get the blood.
You recall in your interview in August of 2009 describing Martin as odd and eccentric?
I always felt like he was a little different, a little eccentric, yes.
And that was before you had any association with him on April 11th of 2007?
Correct.
On April 11th of 2007, in your interview, that was another bad question. I'll restart that one. So, in your interview on August 3rd of 2009, you described Martin's demeanor on April 11 of 2007 as, quote, he seemed appropriately mournful or remorseful as far as, you know, the death of your spouse, to my mind.
Yes, that's a correct statement.
Also in your interview, you indicated to the investigators that you did not notice anything unusual about Michele's body, correct?
No, that's correct, yes.
At the preliminary hearing, we discussed your opinion in relation to when Michele may have had her heart stop. And you expressed that you believed that it was likely within an hour of when she arrived at the hospital, correct?
I think, looking as I recall my preliminary hearing testimony, I believe her heart was stopped when she arrived at the hospital. And I've stated that before. I think she was dead when she arrived at 12:25.
Yeah, and I understand that. I'm talking about when, before she arrived at the hospital, it had stopped, and you expressed at the preliminary hearing that you think that she would have gone down likely within an hour of when she arrived at the hospital.
If that's what the testimony says, I guess that's correct. It's hard to know, I think, exactly when her heart stopped. I don't think, as I recall, the paramedics had any indication of cardiac activity. They never had a pulse, as I recall. I think it's hard to know when she would have had that happen.
You didn't notice any signs of rigor,
No.
correct? And as you indicated, at some point you noticed some lividity.
Correct?
That could have begun within a half hour of when her heart stopped.
Yes.
And you didn't notice anything else about her body to indicate that she had been down for a prolonged period of time, correct?
Poor perfusion, I think we discussed that. The cyanosis we talked about, the lividity on her buttocks and back, those would indicate that she'd been down for some time. Again, hard to know.
That could be, you know, as short as 10 or 15 minutes and have those signs, correct?
Well, the lividity, again, typically starts at about 30 minutes after the heart stops.
Yes.
So we're thinking about that period of time.
Yeah, okay. You also had a chest x-ray done during the course of the resuscitation efforts, correct?
I did, yes.
And that chest x-ray didn't show any sign of infiltrates in her lungs, correct?
I'm looking for this in my notes. I don't recall. I did the chest x-ray partly to check for endotracheal tube positioning, and I don't recall the read by the radiologist as far as any other findings.
You may.
Does that appear to be the radiologist report?
Yes, it is.
And was there any indication of any infiltrates in the lungs?
No, there's no indication.
I'm sorry, Your Honor, may I approach you?
Go ahead. Yeah.
We talked earlier about the intraosseous line,
Okay?
correct?
Yes.
And you didn't recall when that occurred? Does this refresh your recollection as to when you started the intraosseous line?
Yes, it does.
When did you start that?
It says 1250.
And so prior to the intraosseous line, fair to say that the medications would have been given through an IV?
Yes, it says we have IV access and that those meds were administered, those medications were administered through the IV.
During the resuscitation efforts, you also measured Michele's temperature, correct?
Yes, we did.
And that was measured very soon after she arrived, correct?
If it indicates that on the resuscitation record, I don't have access to that, but we did measure it. I don't know what time we did that.
When you measured it, it was 35.7 degrees.
That is correct.
You subsequently attempted to warm Michele some, correct?
Yes.
Would you describe what you did to try and warm her?
We used warm fluid. We used what's called a bear hugger, which is a warming device. That's probably about what we did there for the warming attempt.
And how does the warm fluid work?
My thought at that point, if you look at literature and consider what happens when somebody drowns in very cold water, I didn't know how long she'd been in the bathtub, how cold the water was. And again, as a kind of last-ditch effort to give her any effort, or any attempt, excuse me, or any chance of surviving this event, I thought maybe if she's cold, that we need to warm her. The medications that we use don't work well. Her heart wouldn't work well if she was cold. 35.7 isn't that cold, but in an attempt, again, to give her any chance of survival, that was my thought.
And so that warming fluid, would you put that into the IV?
Yes.
And that would be dripping?
That would be an IV bag hooked to the line to administer warm fluid, yes.
You indicated that 35.7 isn't that cold. Do you know what that would translate to? If you don't, that's fine.
I didn't bring my formula with me to make the change, I'm sorry.
That's all right. We'll do that later. Is it
Normal temperature is about 37. Okay, and give you a reference, 38.0 is 100.4. Okay, so.
And it's fair to say that people have varying normal body temperatures.
Yes, they do.
On April 11th, you didn't suspect drowning based upon what you observed, correct?
That was one consideration, based upon the fact that she had drawn water for a bath.
Right.
And the report was that she had had a syncopal episode and found in the bathtub.
Right.
But again, the top on my differential diagnosis was that of a pulmonary embolus.
And you shared that diagnosis with my client, Mr. MacNeill, right?
I did.
You're familiar with the concept of metabolization, correct?
Metabolism?
Yes.
Yes.
And so medications, when they're consumed, they would then metabolize and ultimately be excreted from the body or filtered from the body.
Correct.
And metabolization rates in individuals can vary dramatically.
They do vary, yes.
And some factors that you've indicated in the past that affect metabolism would be age, correct?
Correct.
Liver function,
Correct.
general health,
Correct.
and the amount of medication that have been taken recently.
That's true. That's fair to say, yes.
I have just one moment, Your Honor.
You may.
That's all the questions I have for now.
Thank you. Redirect.
Very brief, Your Honor. Doctor, with respect to body temperature on a patient who is deceased, when someone dies, their body temperature drops, correct?
Correct.
Are there outside influences that would affect how quickly the temperature would drop, or to what perhaps even degree it would drop?
I would think so. Ambient temperature, I'm sure would affect how,
Ambient meaning,
meaning the surrounding air or the medium in which they're found.
what about a warm body of water?
I would think a warm body of water would tend to maintain a body temperature at some degree and not allow it to fall maybe as quickly as they would if they were out of a warm body of water.
Okay. You mentioned in the cross-examination from Mr. Spencer that the only trauma you observed on Michele that day were, if trauma is even a fair word, but the incisions due to the plastic surgery on her face and hairline and so forth.
Yes, I believe what I saw was on her face, particularly with her eyelids, her eyebrows.
You didn't see any trauma to the back of her head,
No,
her back, her shoulders?
not that I recall.
Okay. Did you observe any trauma to her if she had fallen into the tub?
No,
This way, where she would have cracked her skull or hit her back, shoulders or arms of some sort?
no.
Thank you. Nothing further, Judge.
You didn't observe any signs on Michele's body as if she had been submerged in hot water for a long time, did you?
Not hot water, no.
So no wrinkling of the skin or anything like that?
Well, if somebody's in the water for a long time, they're going to have wrinkled skin anyway. But depending on the temperature, if something's really hot, you're going to see evidence of scald burns, and there were not any scald burns.
Yeah, and there weren't, you didn't see any evidence of wrinkled skin either?
No.
And water temperature actually, if it's less than the normal body temperature, if somebody is submerged in water, that would accelerate the decrease in body temperature after death.
That is correct.
And if somebody is in water and then they are removed and their body is still obviously wet and is exposed to the air, that would create an evaporative effect, which would also accelerate a decrease in body temperature.
That's probably true.
Thank you.
Nothing further, Judge.
May he be released from his trial subpoena?
Jurors may have questions first off.
They may. What's your feeling about?
We'd like to keep Dr. Van Wagner under
Okay.
subpoena.
Do you have questions for Dr. Van Wagner? Anyone? Doesn't look like it. You'll remain under your trial subpoena. If you're needed back, you'll receive notice. You may step down today.
Thank you.
Thank you very much. Next witness.
Your Honor, the state calls Stephanie Hansen.
Ms. Hanson, if you'll come up here to the clerk's desk, please raise your right hand and take an oath right here.
You do solemnly swear the testimony you shall give in the case now pending before the court will be the truth, the whole truth, and nothing but the truth.
Thank you. Please be seated right here and respond to counsel's questions.
Good morning.
Good morning.
Would you please state your name for the record and spell your last name?
Stephanie Brian Hansen, Hansen.
And Ms. Hansen, what city do you reside in?
Alpine, Utah.
Okay. And are you employed?
I am.
And what do you do for a living?
I am a registered nurse.
And how long have you been a nurse?
26 years.
Okay. Can you describe what certifications, if any, you have to practice as a registered nurse or licenses?
I work in the emergency rooms, and so we have many certifications and accreditations that we have to be able to work there. So I am ACLS certified, BLS certified, PALS certified, TNCC, and I am a CNN nurse.
Okay. Do you know Dr. Scott Van Wagener?
I do.
And what's your relationship to him?
I am a nurse who works under him.
Okay. Do you work often with him?
I do.
Okay. I'm going to take you back to the date of April 11th, 2007. Were you in the emergency room that day?
I was.
Did you have occasion to treat a patient named Michele MacNeill?
I did.
What do you recall about that?
She was a patient that was brought in that was having CPR performed on her. She was intubated and brought into the care of the emergency room.
Okay. To help, have you done anything today to help refresh your memory to prepare for your testimony?
Not today.
Not today. Okay. Have you, in anticipation of your testimony today, have you done anything?
I have looked up some vocabulary words and reviewed some of the charting and different things like that.
Okay, thank you. You observed Michele MacNeill on this day.
Yes, I did.
Do you recall about when she came into the ER?
My notes were about 12:25.
Okay. Did you physically see Michele then?
I did.
What did you notice about her?
CPR was in progress. She was intubated, and the usual arrival of a patient was happening from the emergency, the ambulance services, just bringing her in a usual manner.
There was a lot of action?
There was.
Okay. Did you have occasion to actually physically examine Michele and look at her?
I did.
What, if anything, did you notice on
Her coloring was poor.
And when you say poor, what does that mean?
I would interpret that to be lack of perfusion,
Okay. And perfusion means what?
lack of circulation.
Okay. And when you say coloring is poor, how would you describe someone with good coloring versus what you saw in Michele that day?
Good coloring I would consider pink with just a pink in color, and poor would be more ashen gray,
And how did you view Michele on this day?
should be poor color.
The ashen gray look? Okay. You mentioned the poor perfusion. Did you have occasion to touch Michele?
Yes, I did.
How did she feel?
Cool to the touch.
Okay. Are you familiar with Martin MacNeill?
I have heard of him.
Okay. Have you ever seen him before?
That day in the emergency room, I saw him.
Okay. Do you see him in the court today?
Yes, I do.
And where is he seated?
He is to the front table.
You recall what the color of his tie is? Or do you see the color of his tie?
It's
What he's-
blue.
Excuse me. Your Honor, if the record would reflect the identification of the defendant.
Stipulate, Your Honor.
It will reflect that. Go ahead.
You mentioned that you saw Martin MacNeill on April 11th, 2007.
Correct.
And where did you see him?
He was in the emergency room.
Do you recall when you saw him in relationship to the arrival of Michele?
I'm not sure specifically, but it was very short after, if not at the same time.
Okay. What was he doing?
He arrived and came into the room. He was upset, agitated.
And when you say upset and agitated, can you describe what he was doing that led you to believe that?
He looked very worried. He had some sharp movements, fairly verbal.
Okay. And when you say verbal, what was he saying?
I can't recall exactly what he was saying. Some of the comments I do recall is he was upset his wife had this surgery. Why did she do this? I told her not to do this.
Was he insistent in that?
He repeated that a few times.
And what was the part that he repeated a few times?
Just, I told her not to do this. Why did she do this?
Okay. No more questions, Your Honor.
Do you have cross?
Good morning.
Morning.
I'm Randy Spencer. Do you recall having an interview with investigators Robinson and Whitney in this case. And you talked about Michele's coloring during that interview as well.
Yes.
Correct. And you indicated during that interview that that coloring like that could occur as soon as 15 minutes since the person arrived, correct?
Correct.
When Michele, or soon after Michele arrived at the hospital, you took her temperature, correct?
I did not, but it was taken.
Taken. Okay, but you didn't do that yourself?
I don't recall me doing that.
Okay. All right. You didn't notice any lividity on Michele's body, correct?
I was on the right side of her body most of the time, and I did notice some ununiform color on her, by her buttocks and her right lateral thigh area.
And you previously described that as discolored, but you can't tell you that you saw lividity.
I'm not an expert with that.
Okay. All right. That's all the questions I have. Thank you.
The discoloration that you just described, can you describe again where you saw it and how you best can describe what you observed?
For her upper extremities, she was the pale, poor perfusing, slightly gray coloring, and towards her lower extremities, as I recall, she had more blotchy, if you will, or just ununiform color, and then just a little heavier coloring towards the bottom part of her legs and buttocks.
And when you say heavy coloring,
Just a darker, perhaps reddish color. I don't recall.
okay, thank you.
Nothing further.
Do you have any questions for this witness? Anyone? No?
Your Honor, I believe she could be released from her subpoena.
Do you agree?
Yes.
You will be released from your trial subpoena. You may step down. Thank you. Next.
Your Honor, we could call the next witness. I expect her to take about 30 minutes or so. Would you want to do the recess, or would we like to go
Now
forward?
let's, what would you like to do? Would you like to take a break now or keep going? Very silent bunch this morning. I'm seeing keep going, okay? Let's continue.
Okay, the state calls Melissa Frost.
If you'd like to stand and stretch, you feel free to do that. Ms. Frost, would you come forward here to the clerk's desk? Thank you. Please stand here, raise your right hand, and take an oath.
Do you solemnly swear the testimony you shall give in the case now coming before the court will be the truth, the whole truth, and nothing but the truth, so help you God?
Thank you. If you'll be seated here. Go ahead.
Thank you. Good morning, Ms. Frost. How are you?
Fine, thank you.
Will you state your name and spell it for the record, please?
Melissa Frost, Melissa Frost.
What city do you live in?
Harriman.
Okay. And what's your occupation?
I'm currently the Executive Director of Human Resources.
Generally, what do you do for your profession?
Generally, I'm in charge of making sure we're compliant with federal law and we're doing everything that we need to.
Okay. And that's in workplace safety settings?
Yes, I'm also responsible for workplace safety.
Okay. What type of training do you have, education, for this job?
I have my law degree from J. Reuben Clark Law School. I have a bachelor's in political science or government and politics, and I have about 12 years of medical management experience.
Okay, thank you. Were you employed in April 2007?
Yes.
Where were you employed?
The Utah State Developmental Center for the state of Utah.
How long had you been working there?
I started in November of 2004.
Okay, and will you just briefly give us an overview of your duties in that position?
Yes, I was the liability prevention specialist, so my job was to identify, remediate, and prevent any type of liability for that state entity.
When you came to the USDC, how was it doing when it came to liability?
Well, I think general liability, they were probably fine, but they had been number one in workers' compensation claims and costs, and that was very concerning. And so that was one of my focuses, was to increase the safety specifically for that state entity.
Okay. By virtue of that employment, did you come to know Martin MacNeill?
I did.
What was he doing at the USDC?
He was the medical director.
And as the medical director, what was his function in that organization?
Well, he was responsible for the physical health and well-being of all of the individuals who resided there. He also participated on the steering committee, which made decisions about how the entity would act. And he also helped with our safety by making sure that we screened our applicants to determine if they needed to be sent for further medical care, if they were, and when I say applicants, I mean employees, I'm sorry, our employees, to determine if they needed further medical care, which means more than first aid, and that they would need to be sent out to work med.
Okay, so as the medical director, was he part of the administration of the USDC?
Yes.
How about you? Were you part of that also?
Yes, I did go to the steering committee, but I think I would not be a full-fledged administrator. I'd be a mid-level.
Okay, but you did participate in committee meetings?
I did.
Will you briefly describe what the USDC is?
Yes. It's a facility that houses individuals who can't effectively live with their families or in the community because they have mental health diagnoses or even mental illness diagnoses, and they may have some behaviors that just don't allow them to be in the community.
Okay. Will you briefly describe the campus and its facilities?
Yes, it's a pretty large campus. There are multiple buildings, individual buildings where each of the individuals will reside. There's a restaurant area, there's a work area, there's a workshop area, a maintenance, there's administration building with medical services attached to that. There's also the education building, which is the Heather building where I worked. There's a farm area. It's a fairly large campus.
Where is it located?
In American Fork.
You may.
I'm sorry, let me add.
Yeah, go ahead.
Okay, Ms. Frost, I'm showing you a large photograph that's been marked States Exhibit number 34. Will you take a minute and look at that and see if you recognize what it is?
It appears to be the developmental center.
Okay, and is it an overview?
Yes, it looks like it's an aerial view.
Okay. And based on the layout of the buildings and your recollection of your time there, does that accurately and fairly represent the developmental center campus as you knew it?
Yes, it appears to.
Okay, the state offers number 34, Your Honor.
No objection, Your Honor.
34 is received.
And may I have permission to publish it to the jury?
You may.
Thank you. May I approach it?
Are you, oh, here? That's great.
Okay, and Your Honor, may I have the witness step down for a minute?
Go ahead if you'd step down and respond to questions.
Ms. Frost, will you mark with that pen?
I'm sorry, it's been received.
I'm sorry.
So do you have any objection to it being marked? It's,
I don't, Your Honor.
okay.
Will you indicate on there where your offices were, where the Heather building that you mentioned is with an HR? Actually, let's go with Heather building, HB.
And honestly, I'm having a little bit of trouble with this aerial view. It's the first time I've seen it.
Okay.
So I can identify some areas, but can I make sure that I understand?
If you want to take a moment to study it, that's fine.
Okay, I think I now have.
You have
this
yourself
areas.
oriented?
I apologize, but.
No, that's
I
all
haven't
right.
seen this before.
It's my fault for springing it on you. If you don't mind, do you mind stepping just to the left so the jury can see what you're indicating? Would you be able to indicate by writing the letters HB on the Heather building where you worked or nearby it?
Well, I believe this is the administration building with the large parking lot.
Okay,
And so I believe this would be our building right here.
okay, will you go ahead and mark that as HB then? And will you put an X in that HB building in the approximate area where your office was? Will you put a circle where the conference room was? And then will you put an AB on the administration building? Did you know where where Dr. MacNeill's office was?
Am I allowed to talk or just mark?
No, please, just, first of all, do you know where the office was?
Yes, I do.
Okay, will you mark an M where that was?
Via medical services behind the administration building.
Okay. Back to the Heather building, would you mark on there where the main entrances to that building were? Are there any other entrances to that building that you are aware of?
Yes, there's an emergency exit here, and there's a door that is kept locked here in the kitchen.
Okay. Thank you. Let me go ahead and have a seat. Will you tell us about the safety fairs that you held at the USDC?
Yes. We instituted a safety fair because we felt that we needed to bring safety down to the basic level of the average employee. So we studied the types of injuries we were having, and then we instituted the fair, which was typically an all-day event. We had 3 of them, all 3 years I was there. And we would have tables going around the room in the conference room of the Heather building, and each table would represent a different kind of activity that might be unsafe.
And the conference room in the Heather building where you had these safety fairs, is that the circle that you marked on that, on
Yes.
Exhibit 34? How were these booths that you mentioned, how were they managed?
Typically, we had someone from that area. For example, if it was bloodborne pathogens, we had a nurse, our infection control nurse, who would man that table. Workers' Compensation Fund came and manned their table with information about benefits through workers' comp. We had PEHP come and talk about general overall health and wellness. We had medical services there so they could talk about the services they provide and be sure that employees understood the protocol about where to go if they were injured and when to complete their reports. We had numerous booths. We had some that were every year and then some that would change.
When it comes to medical services, who would be in charge of making sure that booth was staffed?
Dr. MacNeill.
You mentioned that there were 3 safety fairs in those 3 years that you were there.
Yes.
This is an annual event.
Yes.
What was Dr. MacNeill's attitude or participation in the safety fairs in previous years?
Well, do you want me to address both issues? I think he participated in the safety fair because he knew that Karen, the director, really wanted us to increase our safety, but it really didn't seem like it was extremely important to him.
Strike that, it's not relevant.
Sustained as to whether he thought it was important.
Okay. As far,
Let me ask you this. Instead of talking about what Dr. MacNeill thought, what level of participation did you observe from him?
the participation was that usually he would attend for a brief time, very shortly, and he would provide a list of people from his department who would be manning the table each day, and they would rotate, and there was usually someone there with rare exception.
Do you remember April 11th, 2007?
I do.
Do you remember that day well?
Yes.
Why is that?
Well, it was our third safety fair. I was really excited about the participation. It was also my last day of employment with the developmental center, so it was kind of a culmination of all of my efforts for that.
What time did you arrive at work that day?
Before 6 o'clock in the morning. We started at 6, so I think even before 5, it was very early.
Okay, and what time did you leave?
2 a.m. the next morning.
Okay, so this is a very big, long day.
It is.
Did you leave the campus at all during that day?
No.
Okay. Where were you during April 11th, 2007?
Most of the day I was in the conference room because there are different activities that take place and I want to see what our turnout looks like. We have random prize drawings. Everyone has to complete a safety quiz. They have to get an answer from each of the tables and fill it out and put it in a box. And so most of the day I was in that room, but I did occasionally go back to my office to take a phone call or to make a phone call and to get the plaque. And so.
Okay. Is it fair to say you were in charge of this?
I was.
Okay. Did you see Dr. MacNeill at all that morning?
Not until we gave the award.
About what time was that?
The award was between 11 and 11:15.
Okay.
We were done, I think, by about 11:15.
You mentioned the award. What's the point of that award?
Well, we picked a direct care, which is where they were housed. We called those direct care staff, so we always picked a direct care staff, and then we picked an auxiliary staff who had exhibited the best safety record and had improved their safety. So there were always two groups getting an award. And we wanted to make sure that we did that at the time of day that most people could see it, so they would be incentivized. And we wanted to really recognize and reward their behavior.
Okay, I was going to ask why you wanted to do that when most people could see that.
Because if you get recognized, there wasn't a lot of positives, and so that was a really important positive, and I think that really helped people want to be safe because there was importance tied to it.
What time did you have the award ceremony set up so that most people could see it?
11:45.
This year, in 2007, who is receiving awards?
It was Dr. MacNeill's department, and I believe Willow Creek was the other department.
Willow Creek, is that one of the?
Direct care.
Okay. Or did the award ceremony happen as it was scheduled?
It did not.
Was it rescheduled?
Yes.
Do you know for whose benefit it was rescheduled?
Yes.
Objection, Your Honor, hearsay. May we approach on this?
Yes. Ladies and gentlemen, we'll take our morning break now. It's a little past 10:30. I think that will be about 20 minutes. Remember my admonition to you, don't form or express any opinion about the case. Do no research on your own. It's your duty not to discuss any subject of the trial amongst yourselves or with anyone else. Avoid internet, television, radio, news, broadcasts. Court's in recess.